Good evening, everyone, and welcome to our pregnancy care update. My name is Helene. I'm the Workforce Officer Development at Western Victoria. I will be your facilitator for this evening alongside my colleague Jade, who is also a Workforce Development Officer at the PHN. This 2-hour pregnancy care update will cover pain and bleeding in early pregnancy, miscarriage and ectopic management, along with an update on Barwon services. There also is RACG points and 4 Bowen Health Shared Care accreditation points for those GPs attending. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in today. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to elders, both past and present, and I wish to extend that respect to any First Nations people connecting today. We commit to working together in the spirit of understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations and will work together on closing the gap. Little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. Jade has that link up on the screen at the moment. I have our upcoming events on the screen. You can register for these on our website. Jane's got the link there. Just a little bit of information about our annual Primary Care Refresher Conference that's open for registrations at the moment, and this will be held on the 4th and 5th of June. It is free to attend and open to all primary care professionals, including practice nurses and practice managers. There will be a GP stream and a primary care stream running concurrently. The program has been uploaded in the handout section. The 2-day event is being run online, but attendees have the opportunity to attend in person on the Saturday at venues in Geelong, Ballarat, Horsham and Warrnambool. Please note that the face-to-face places are strictly limited, so we recommend that you register and scan with your QR code with your phone. That link is and the QR code is on the screen at the moment. Please make note of that West Vic Health Pathways slide relating to this topic that is on the screen. And for this evening's webinar, all participants will remain on mute for the course of the meeting. Should you have any questions, please type them in the questions box and I'll address those questions at the end of the sessions on behalf of yourselves. Our speakers for this evening are Dr. Alexandra Bonner and Dr. Deb Karmakar, Obstetrician and Gynaecologist. We also have Kate Cohen and Edwina, Clinical Midwife Specialists, who will be providing input into this session. I will now hand over to Alex to begin. Thanks, Alex.
Thanks very much, Helene. I've shared my screen there. Just let me know if there's any issue. Thanks to the PHN for giving us this opportunity to give you an update on Barwon services. So you can't see my screen?
Yes, we can. Can see your screen.
Very good. And I'm just wondering if there's a way. There we go. Okay, great. I was just thanking the PHN for giving us this opportunity to give our GPs an update on our early pregnancy assessment service. And thank you to everyone for giving up your evening to tune into this. And we'd really welcome questions if we've got time at the end of this little segment or at the end of both Deb and my presentations. So I'm going to be speaking tonight with Kate Cohen, who I've been working with really closely in the restructuring of our Epas service. And Edwina McClean's just recently joined our service and she's listening in tonight as well. Hang on, just got to be able to move my slides. Sorry guys, just a second. Oh, there we are. Very good. All right. So I'm going to speak for probably about 20 minutes, half an hour. I'll keep an eye on the clock. I want to give you just an overview of our newly restructured service and also a bit of an overview on pain and bleeding in early pregnancy, as I think that this is really very much a common presentation managed by primary care, because often we won't see pregnant women in our clinic at Bowen Health, in our antenatal clinic, until 14 weeks is their typical booking in visit. So I think a lot of these issues are often managed very well in primary care. I'm going to give you a bit of an overview of miscarriage management, ectopic management, retained products of conception, and endometritis, which is relevant both for miscarriage but also after medical and surgical abortion. So some principles of management, and also who to call for further advice and assessment. And also talk to you a little bit about recurrent miscarriage, which is a particular interest of mine. And we're in the process of setting up a recurrent miscarriage clinic within our Epas service, really looking at what investigations are evidence-based and management options. Then Kate's going to go into more detail around bereavement and counselling for early pregnancy loss. I guess acknowledging that a lot of GPs at the moment manage particularly miscarriage and pain and bleeding in early pregnancy themselves in their practices. So Kate's going to share her knowledge with you regarding that. All right, so in terms of what we offer at Barwon, we have a clinic Monday to Friday, half day, so in the afternoons, Monday to Thursday, and then Friday morning. The referrals can be put through on HealthNet using the GP referral template, and we just ask that you attach any relevant history, relevant pathology results, and ultrasound scans. There's a little tick box for you to be able to reference. The emergency department also internally refers to us. All the GP referrals are faxed through to maternity reception where they're processed, but then they're actually given to our Epas midwives who triage them. They then call the patient and make the appointments when appropriate. And they also will do some counselling over the phone depending on the situation, so that the woman will know what to expect when she's attending the clinic. And it's also then those midwives, so Kate and Edwina, are also present in all of our consultations in the Epas unit, and they will often do a lot of the follow-up, which are a lot of phone reviews. And so we think that that continuity of care is really central to the woman's sort of experience during pain and bleeding in early pregnancy, and we're getting lots of positive feedback that that really makes a difference to them, not having to tell their story to a new person every time. So who do we see in the Epas service? Oh, sorry, actually, I probably jumped forward a bit too quickly. So the midwives have an email address, so we can put these in the chat at the end, or I'll give them to Helene. So the Epas Clinic at barwonhealth.org.au, but we ask that the referrals don't go directly through to there because they need to be processed through the hospital system, so it all ends up on the electronic medical record. But they do have a mobile phone number, and they're available for contact from women or also from GPs with questions or concerns on that mobile number. There's also the outpatient number there. Obviously, anything that you were very concerned about, or if you're sending a patient through to the emergency department, you can still contact the gynae registrar on call, and you can reach them through the Barwon Health switchboard. Okay, so who do we see? So we see women who have pain and or bleeding who are clinically stable because it is just an outpatient clinic. And we see women less than 14 weeks, so up to 13 plus 6. For women that have had a confirmed miscarriage on ultrasound, women who have retained products post-miscarriage or abortion, women who have a slow rising beta HCG and you suspect that they are at risk of this being an ectopic pregnancy, so you can hand over their care to us to follow through. Women who would prefer not to see or who will triage the emergency department are women who are clinically unstable and require emergency review, and I'll go through the red flags on the next slide. Women who are more than 14 weeks pregnant do need to be seen in our pregnancy care clinic. And so if we receive those referrals, we'll often contact the GP and get them to reroute the referral through to the pregnancy care clinic. Look, our service is limited in terms of resources, so we don't want to be providing dating ultrasound, though we will be providing some additional scans for women who have had a history of recurrent miscarriage just for reassurance, but we won't be providing formal dating scans. and you'd be surprised, but we do still sometimes get referrals for women who aren't actually pregnant. So it's not a walk-in service. Appointments are required. The Epas midwife will contact, so just so you know what to tell your patients when you put a referral through, they should be contacted within 24 to 48 hours of the referral being sent through. And if there's any outstanding investigations that need to be done, the midwife will try to assist the woman in accessing those. Now, people can bring their partners and the support people, but we ask that they don't bring children just because it can be difficult to manage in a clinic space. We do try to separate the waiting room for Epas from our gynae and pregnancy care clinics so that women who are experiencing miscarriage don't need to sit there with amongst other pregnant women. As we've heard from sort of consumer advocates, that this is very important to them. So in our clinic, who do the women see? So we have a junior doctor, and they are being supervised by a consultant gynaecologist, and also in the appointment as appropriate will be the Epas midwife. And we can organise any further tests or investigations that are needed. We ask that women come with a full bladder in case we need to do an ultrasound, and we always start with the transabdominal scan, so a full bladder is great. And then we've moved to a transvaginal scan as required. And then as I'll go through the management of miscarriage and ectopic, but we can then really do a lot of the management at that initial visit. And so we can provide medication from our clinic directly to the patient, such as misoprostol. Methotrexate for ectopic management needs to be provided over in the Andrew Love Centre over in the hospital, and if women require a suction D&C, that can be arranged usually for the following day, which is a service that we're really proud of. Okay, but when should women seek urgent medical attention? So for example, if you had a woman that has had a confirmed miscarriage and you've on their ultrasound, or that they've got a bit of pain and bleeding and you've sent through a referral, tell them that they should seek assistance in the emergency department if they're getting heavy bleeding that they're concerned about. And that's always difficult to quantify. But I would usually, just to help give them sort of some guidance, so 2 sanitary pads in an hour, which is then ongoing, or large clots, bigger than a golf ball. And again, obviously 1 clot, not a worry, but if it's ongoing, severe pain that they're not getting any relief from with simple analgesia such as Panadol or a heat pack. Shoulder dip pain, we always worry about that in the setting of ectopic pregnancy can be a sign of a hemoperitoneum. If women are feeling weak, dizzy or collapse, or if they're unwell and worried about infection, so vaginal discharge that smells offensive, particularly in the setting of retained products of conception, and I should also say their fever as well. I'm happy to answer any questions about that. Okay. Sorry, my slides just aren't moving. I wonder if there's a trick. There we go. Okay. So just as it's so funny talking with no feedback. Usually I'd sort of open it up for questions at this stage, but I'll just keep on keeping on. Okay, so in terms of pain and bleeding in early pregnancy, which I guess is such a common presentation in the GP setting, our focus is on wanting to follow that woman through until we've been able to confirm that it's an intrauterine pregnancy. Certainly between 3 to 6 weeks of gestation can be a real grey zone of uncertainty. And so what I've got, I know these slides look a little bit busy, but they are, I guess, the flowcharts that we're now using to help guide our junior doctors and midwives in our clinic to provide sort of consistent care. I'm happy to provide the set of, it's sort of like an Epas manual. I'm happy to provide that to any GPs who are interested if it would be of assistance in their own practice. So, you know, in terms of broad principles, so we'll accept a referral, less than 14 weeks, pain, bleeding, confirmed miscarriage. There's our numbers there. If you've got concern, if there's red flags, then sending women straight into ED and letting the gynae registrar know will help facilitate their journey. Also then to the right is that's really more guidance for our registrars in terms of doing resuscitation and acute assessment. Some guidance there below here regarding I guess, in that broader Epas assessment and what we're doing. So we just want to take, history from the woman, trying to assess their gestation based on their last menstrual period or other ultrasounds that they've had, significant gynecological history, such as previous ectopic pregnancy, cesarean section, any gynae surgery. Was this a planned pregnancy? Were they on contraception? And I guess at that point, I'll always indicate to them that at this point, our main focus is on confirming that it's an intrauterine pregnancy, and then we can help support them depending on what they decide to do with an ongoing pregnancy. An overall examination, I won't go into that in much detail. Then a quantitative beta HCG. And then if they've already had previous quant betas, then to look at their serial beta HCG trend. And then we'll do an ultrasound transvaginally, we'll do an FBE to check the hemoglobin, a blood group, and then as indicated, a urine MCNS and an STI screen. What I might do is I might just skip to the next slide. So sorry guys, a bit technologically challenging. Here we go, okay. And so the next slide is going to talk to you about how we assess pregnancy location and viability in the setting of suspected early pregnancy loss. But before I get to that, because what we're thinking about as our three different tools are, is this an ectopic pregnancy? So with that, we'll look into the history for any particular risk factors, and then obviously diagnosis on ultrasound, and I'll talk to you through the different factors which influence management pathways. Is this an intrauterine pregnancy? And that's defined as both a gestational sac and a yolk sac. Now that's important because a gestational sac by itself can actually just be a pseudo sac and it could still be an ectopic. So we really want to see a yolk sac to confirm that it's an intrauterine pregnancy. And then is the pregnancy viable? So has it got adequate interval growth between two ultrasounds, and can we now see a fetal heart rate when we would expect to? In the setting of a positive beta HCG, but a normal pelvic ultrasound, we would define that as a pregnancy of unknown location, which will often that's often a source of questions from our junior medical team. What we do is we track the beta HCG. And every 48 hours, as you know, in a normally growing pregnancy, it should double. So what I might just do now is skip to the next slide, because then I can talk you through how we interpret the trends of 48-hourly beta HCG. Okay, so I'll just move on to our next slide there. All right. So skipping ahead to here, so pregnancy of unknown location. We'll get our two beta HCG levels and compare the results. So if the fall from the first to the second has been greater than 50% of the overall total, then it's likely going to be a non-viable intrauterine pregnancy, but just so small that we couldn't yet see something on ultrasound. I think you can be confident after two beta HCGs and a big drop. Look, I would say in this situation, we always still need to track the beta HCG to 0 because we've never confirmed the location of the pregnancy on ultrasound, but you can then start doing them weekly. And as long as they're trending down, reassuring the woman, just that you'll be checking them weekly until it's back to 0. When we're doing that within our own clinic, we get the midwives to give the patient a call every week. If the beta HCG has risen greater than 66%, very exact there, but a good rise, so maybe not double, but it's still a good rise, it's likely to be an intrauterine pregnancy. We can't yet exclude an ectopic pregnancy. The numbers that we look for, so this guideline is using 2000, but certainly over 1500. Once a beta HCG is over 1500, we should see a gestational sac inside the uterus. If the beta is still low, that's when we'd push out when we're going to do the next ultrasound, because we don't want to be doing ultrasounds too frequently because we don't see the growth that's required. If it appears that the beta-HCG is plateauing, and by that I mean a low rise or a low fall. That is always a concern for ectopic pregnancy. So in that situation, we'd repeat an ultrasound, and depending, we really try to individualise our care, looking at the woman's background history and what their plans are for this pregnancy in terms of how conservative our approach is. But we have quite a low threshold for methotrexate management, which is medical management of ectopic pregnancy, because we suspect that there is a pregnancy somewhere, just not in the uterus, and that plateau of beta-HCG is suggesting that that it's not a normally developing pregnancy. Okay, so that's pregnancy of unknown location. In terms of an intrauterine pregnancy, actually, maybe before I get to that, I'll just quickly talk about ectopic pregnancy. So, yeah, I already talked in the setting of pregnancy of unknown location, beta-HCG over 1500, no gestational, intrauterine gestational sac will treat as a suspected ectopic. But obviously, if you've got a positive beta-HCG and the nexal mass suggests suspicious for an ectopic, I'll talk about the criteria, but we'll then treat them as an ectopic either with medical or surgical management. There are the more rare types. So 95% of ectopics are tubal, but there are more uncommon types of ectopic pregnancies in the uterine cornu, cervical, cesarean scar, and ovarian. And that would be a consultant-led decision as to whether we manage that at Geelong with, say, multi-dose methotrexate or surgery, or if we refer up the road to the Royal Women's. All right, so in the setting of an intrauterine gestational sac and a yolk sac, so great, we have an intrauterine pregnancy, but is it viable? So obviously, very reassuring if we see a heartbeat. If the fetal pole, sorry, I just lost my train of thought because I thought I'm going to start talking about miscarriage, but I might just hold off on that. If there's no heartbeat visible, then we look at the size of the fetal pole. If the fetal pole is greater than 7 millimetres, then we should expect to see a fetal heart. So that's suspicious for a miscarriage. Similarly, if there's no fetal pole yet, but the mean sac diameter, so initially the sac grows, then the yolk sac, then the fetal pole within that. But if the gestational sac has grown to over 25 millimetres, we definitely should be seeing a fetal pole. So that also, a large sac with no fetal pole, is also, that would diagnose a miscarriage. All right. So I'll go to my next page there. I might not go into this in a whole lot of detail. This is just a helpful slide talking about what we expect to see at what gestation, and then the clear diagnostic criteria for a miscarriage. So some of the language has changed in the last couple of years. So there used to be like the terminology of a blighted ovum. We don't use that terminology anymore. Now we just call it a missed miscarriage. So as I said, gestational sac greater than 25 millimetre with no fetal pole and no yolk sac, and a crown rump length of greater than 7 millimetres with no fetal heart. But also, and probably more frequently, we'll see women that are having interval scans and not seeing adequate growth on those scans. So usually we'd expect the fetal pole to grow by about 1 millimetre per day. So I wouldn't do scans any closer than, say, 7 days apart. And so depending on the whole clinical scenario, and we'll use that information to determine what's going on. And that can be a really difficult time for women because it's really a grey zone and we can't give them a clear answer sometimes initially. We just need to give it more time. All right. So I talked briefly, I've just got one eye on the time. Oh, I've already talked for 25 minutes. There you go. So tubal ectopic, they're common. I should say they're uncommon but not rare. So 1 in 100 pregnancies. Main risk factors are a history of PID. Those women are at 10% risk of an ectopic. If they've had a previous ectopic, IVF pregnancies, if they've got pregnancy with an IUD in situ, or if it's in the setting of using the morning after pill emergency contraception, they're increased risk factors for ectopic pregnancy. So just here, I'm just talking about expectant medical, and I'm trying to move this a little bit around, yeah, and surgical management. I think the broad principles are if the woman is well and her beta-HCG is very low and it's already falling, then this is quite an unusual scenario really, but we can do expectant management where we just track their beta closely. Every 48 hours times 3 and track it back to 0. More commonly, if we see that the beta HCG is less than 3,500 and the ectopic tubal mass is less than 3.5 centimetres and the woman is stable and she feels comfortable with the follow-up required and is able to access the follow-up, then we can offer her a methotrexate injection. Methotrexate is a folic acid antagonist, so it blocks the division of rapidly dividing cells. But the follow-up is really essential. We need them to do bloods at day 4 and then at day 7, and we'd expect a 15% drop, but in that interval. About 15% of women require a second dose of methotrexate or at that point would opt for surgery. So once we see that adequate drop, again, we do weekly beta-HCG until it's back to 0. Surgical management, so if the woman's unstable, any signs that there's tubal ectopic rupture, basically if there's any contraindications to medical or expectant management, and the surgery of choice is a laparoscopy and a self-injectomy, so removing the tube. In terms of general counselling points, I'd say that that doesn't halve your fertility, but it does have an impact, probably about 20%. But with one healthy tube, you can ovulate from the other side and the egg can actually drift down that one healthy tube. And the counselling I give to women for subsequent pregnancy is just to track their periods, know when their period's late, do an early pregnancy test and seek care early with their GP with a serum beta-HCG and then a dating scan early so that we can confirm that it's an intrauterine pregnancy. Okay. Now miscarriage. So common condition, the most common pregnancy complication. 20% of confirmed pregnancies will miscarry, and you can see there that as your age increases, your risk increases. The most common cause, we think, is that probably about 50% of miscarriages are due to aneuploidy, which is usually a random genetic problem with the chromosomes, not something that's inherited from the mother or the father. And there's certainly an age risk factor there. So as your age increases, your risk of aneuploidy, because your eggs are older and your genetic material is more fragile, that risk increases. Other common causes due to abnormal placental development, which can be due to underlying medical problems or acquired thrombophilia, and then uterine structural problems such as fibroids or a uterine septum. So once we've diagnosed that that woman has experienced a miscarriage, Kate and Edwina, the Epas midwives in the clinic, will do counselling. The doctor in the clinic will also provide them with their options. And we are trying to really, like, anything's an option, you know, in terms of expectant medical or surgical management, but we do have some, I guess, recommendations in terms of how to guide women. And really, in terms of broad principles, expectant management is when the pregnancy is earlier, and also if the miscarriage process has already started and the woman's already got some pain and bleeding, and that they've got good supports at home and that they know what to expect and they feel like they're able to manage that at home. Very similar with medical management. So, for example, a woman this is the first time she's been pregnant and the pregnancy is 11 weeks size, I would not be recommending for her to go down the path of medical management. It certainly is an option, but we need to prepare women for what to expect at home. And misoprostral management certainly can result in quite strong pelvic pain, crampy pain, and heavy bleeding. And so it's just really important that women know what to expect. We'd actually added mifepristone to our misoprostral regime, as there's now good evidence that improves outcome. And I might just keep moving along here. And so surgical management, a suction D&C, it's a day surgery procedure, and we can organise that from our clinic, and we usually organise it for the following day. The woman just needs someone to drop her off and pick her up. I think that's all really. And then routinely after a suction D&C, we'll ask women to follow up with their GP at 2 weeks, but we'll also put in a phone call to them at 2 weeks to ensure that their bleeding is settled. And also sometimes that's when women will take up more of the counselling and bereavement support that the Epas midwives provide. Okay, so retained products and endometritis. We've tried to put a bit of a guideline together because there is so much variation in practice. We see retained products with or without infection in postpartum setting, post-miscarriage, post-medical or surgical abortion. And I just want to say at this point, it's also really important after medical termination of pregnancy, the follow-up with their beta HCG tracking or an ultrasound in the rooms at 2 weeks to confirm completion. And if there's any issue around retained products, either providing them with further medical management or referring them into us for surgical management. And I'll just also flag that's something called Asherman syndrome, where we're cautious in the retained product setting, and particularly because there's almost always infection there as well, and the risk with a curette that we can damage the endometrial lining and cause scarring within the uterus, which can affect future fertility. Basically, we scrape the endometrium away and it doesn't grow back. So we're very conservative. We very much try to manage things with antibiotics. If antibiotics don't work, then misoprostol to try and get the uterus to expel the products. But then if we really need to, if the woman's unwell or it's a large amount of tissue, we'll admit them for IV antibiotics, usually for 24 to 48 hours prior to a gentle suction curette. In terms of the antibiotic regime, we just follow the therapeutic guidelines for post-procedural pelvic infection. In the GP, that primary care setting, I would say if you had someone just with some unexpected, like heavier bleeding than you'd expect or a bit of crampy pain, just give them oral antibiotics for a week before even doing an ultrasound, and that will resolve it for the majority of women. Then at a week, doing an ultrasound, we look to see the quantity. If it's greater than 3 centimetres, we would usually offer the woman surgical management, as that's a large amount of product. Okay. All right, and I think we've just talked that through there. But yeah, antibiotics, antibiotics, antibiotics. So first line, always antibiotics. And then if that's not resolving it, then we go to medical or surgical management. And I think that's something that we can manage quite well through Epas, because we're a pretty dynamic clinic in that we see women really quite quickly after they're referred, and we're always happy to provide any support over the phone as well if you're unsure about what path of management you should take. Now, just before I finish, I just want to quickly talk about recurrent miscarriage, because we are in the process of setting this up. It will be provided fortnightly within the Epas setting. Inclusion criteria will be for women that have experienced 3 miscarriages. And that is about 1% of women will experience 3 miscarriages. But, you know, there's a bit of discussion around what is the definition of a recurrent miscarriage, and I'm certainly of the belief that for a woman who's experienced 2 miscarriages, and that's 5% of women, depending on their obstetric history, this can be really distressing for them, and the idea that they need to have yet another miscarriage before any investigations are undertaken, I think, is really not very reasonable. There's also been some literature come out to say that really in the setting of recurrent miscarriage, we only find a cause about 5% of the time, and that's no different between 2 or 3. So I think we shouldn't hesitate to start investigations after 2 miscarriages, particularly for women who have had consecutive losses, have no living children, advanced maternal age, and other medical risk factors that we could help optimise to improve their pregnancy outcome. So what I see the role of this clinic being, it moves when I don't even want it to, is really to undertake a detailed history with that couple, and review investigation results, provide targeted counselling. And a lot of this is really just acknowledging what they've been through, even if we're not going to be able to identify a cause and give them a treatment, just acknowledging their loss and their stress and how difficult it is for them to be then embarking on another pregnancy. That additional support, I think, is really valuable. And hence then I want to be able to put together a plan for their future pregnancy so that they feel like they've got some sense of a plan, and also provide them with support in early pregnancy the next time around, and be able to just get them in for frequent ultrasound assessment and reassurance. Now, in terms of evidence-based investigations, what we will be doing through our clinic is we do antiphospholipid antibodies for lupus anticoagulant and anticardiolipin antibodies, because we think that this affects placental implantation and it can be treated or managed with clexane and aspirin in early pregnancy to improve pregnancy outcomes. We do a thyroid function, so a TSH, looking for subclinical hypothyroidism, which we would manage with thyroxine. Obviously, any thyroid disease also needs to be managed. We do a transvaginal ultrasound to look for any structural abnormalities, do chromosomal testing of the pregnancy in that miscarriage setting, and just I try and identify a cause for that current miscarriage, but actually more valuable is a maternal and paternal karyotype. And what we're looking for there is a balanced translocation, which means that either, so just say the mother has a balanced translocation, means that they have an extra bit on their chromosome and it's balanced, so they have 2 bits. But then when they conceive and they share one chromosome, now it becomes unbalanced. And then we think that can affect up to 3.5% of couples, and that can be really valuable in identifying that. And we would obviously then flag them for genetic counselling. So what else will we do in this clinic? We talk to them about genetic carrier screening, which is really just something that we should all be talking to women for pre-pregnancy counselling. The common test being PREPARE, which is for spinal muscular atrophy, Fragile X and cystic fibrosis. And that's a test that costs around $350, but I think is becoming available through Medicare, and we're going to be able to access it through our public clinic. Doing a mental health screen and identifying and supporting them, treating any mental health problems, because often pregnancy loss can be a really stressful event for women and their partners. Optimising any medical and lifestyle factors, and this is not to be underestimated, so particularly just managing any medical problems, smoking cessation and managing their BMI. And then also talking to them about obstetric risks, depending on their history, whether they're at increased risk of preterm birth, fetal growth restriction, and stillbirth, but, you know, and putting together a pregnancy plan for the future. Oh, sorry, none of my buttons work. I don't know what's going on. There we go. Okay. Now, I do need to acknowledge there are limited treatment options. So a lot of the therapeutic benefit of this clinic will just be the counselling. But TGA approved, not on the PBS yet, is progesterone. And there's a lot of talk around progesterone. So I just wanted to try and help clarify this for you. So Progesterone Pessary, so in the first trimester, the dosing being 400 milligrams BD from diagnosis of pregnancy until, well, the trial say 16 weeks, but really realistically at least 12 weeks. And I'll go into progesterone on the next slide. I talked about thyroxine, we talked about aspirin and clexane. All right, very good. Now there's a limited evidence from the rest of the list there that I don't really have time to go into today, and wouldn't be offered through our clinic due to the lack of an evidence base, and there's sort of a watch this space in a lot of those situations. But what we really hope to be able to provide is frequent review for reassurance with frequent ultrasound. Okay. And I guess it's also just to really acknowledge that a lot of women feel quite lost in the first trimester, particularly if they don't have a regular GP. So we really encourage them to find a regular GP. But because we don't see them in our pregnancy care clinic until usually around 14 weeks, I feel like this is a really sort of under-recognised time, which can be really challenging for women. So we really wanted to provide additional support that within our sort of limited resources. Okay, so progesterone. There's been 2 really big RCTs, Promise and Prism, that looked at both recurrent and spontaneous miscarriage. Basically, the outcome was that in the setting of bleeding in early pregnancy with previous miscarriage, progesterone has a positive role and a positive impact, and that correlation increases the more miscarriages you've had in the past. So if you've had 1 previous miscarriage and now you're getting bleeding, the live birth rate with progesterone versus placebo was 75% versus 70. 3 previous miscarriages and bleeding, it was 72% versus 57%. So there is a role. The issue is the cost, and we're looking at ways in which we could in some way subsidise this within our clinic, but I think it's going to be limited. Uterogestin is so you can get it at Chemist Warehouse. It's $90 for 42 days. That works out at $9 a day. And so, look, I guess watch this space. I think it's important to tell women that it's available, but acknowledge the cost. And then sort of rationalise it. So using it just 12 weeks rather than 16 weeks, and maybe even in some settings using a lower dose. But yeah, happy to answer any questions about that. Okay, now I'm going to hand over to Kate. We've also got Edwina on the line, but Kate's going to present some slides on bereavement. Now, she's had some technological issues with her old laptop, so I'm going to do the slides for her. Are you there, Kate?
Yeah, can you hear me? Oh,
yeah, great.
Yes. Woo. Yes. Okay. I'm going to try and fly through these slides, but I just want to say thank you for having Edwina and I. The role of the midwife in the Epas Clinic only started in October last year, and since then we've definitely received a lot of positive feedback from the women, and a lot of that is to do with the bereavement side of things that we're offering women at either on the phone or face to face. So I've just put some slides together just to refresh our memories about the language that we should be using and the language that we should try to avoid, because this can make such a big difference. So first thing is that we should never make any assumptions with the couple that we're caring for. Every couple's different, and just to be aware of our body language when we're speaking to them, making sure we have eye contact unless there's any cultural reasons why that's not appropriate, and then offer your condolences and it actually acknowledge their loss. And so these are some phrases that you can use to kind of start that ball rolling. So just simply saying, I'm so sorry for your loss, or I'm sorry that we're meeting under these circumstances. A really good phrase to use is, there's nothing that you have or haven't done for this to happen, because majority of the time, the first thing that happens when a woman's been told she's had a miscarriage is she thinks straight away, oh my gosh, I did this, or I didn't do that, or I ate this, or whatever. So that can really help, just saying those simple words. What else? That I can't imagine what you're going through, but I want you to know that I'm here for you. Another good thing is, when you're talking about different, services or anything like that, is other women or parents have sometimes found it helpful to do this or to do that, and giving them options. Telling them that they can ask any questions. I'm not sure how it would work in the GP land, but we tell the women that we see in Epas, you can always contact us, either call or text us if you've got any questions, and then we'll get back to you. It's important also that silence is okay. Just sitting with them while they're crying, while they're grieving, can speak volumes. And I know part of the human nature is kind of fill that silence with chatting and all of those things, but sometimes it's good just to take a moment and let them grieve and just hold that space with them. It's important that we're actively listening, using simple, straightforward language. If we've got written literature, give that to them as well, because they're only going to take a small percentage in. Try not to rush them, which would be hard in, again, GP clinics, quite busy. So if you can, try not to rush them and just let them know that there's no right or wrong way to grieve. Next slide, Alex. Thanks. These are just some things of what not to say, and this has come through, you know, women's experiences, you know, in literature and all of those things. So, you know, don't ever say it was meant to be or it's God's plan. Try not to use abortion or spontaneous abortion, rather, you know, use miscarriage rather than those words. You know, things like at least you can fall pregnant, go on, have another baby. A miscarriage is not a baby, it's just tissue. And I'm sure none of you GPs would ever say any of these things, but it's good just to know that women will be told these things by, you know, family members and all of those things. So if we can, try not to use those, you know, use that language. Another thing is, you know, referring the baby as products of conception. Obviously, you know, in our medical side of things, we use that language all the time, but when you're actually speaking to the women, you know, try not to use those words. Use pregnancy tissue instead, or sometimes just simply asking the woman, look, some of the language I'm going to use might, you know, might be a bit insensitive. Is it okay if I say pregnancy tissue, or would you prefer me to call it a baby, or whatever like that? And just take, you know, follow the lead from what they're saying, the language that they're using. You can pick up a lot from what they're saying, and then use that language to them as well. And then just a couple of other little things. So rather than saying it's not viable, saying the baby will not continue to develop and will not survive. And same with incompetent cervix, instead saying your cervix is opening before it should. Next slide. So these are just some of the support services that we talk to women about. So the, like Alex said, the initial phone call we have with the women to say that we've received their referral. We also talk to them about how they're feeling emotionally and gauge how they're going. And then most of the time we do actually send them the links, mainly to the Pink Elephants and the SANS website, just so they've got something there until they see us. So these are our most common ones. Probably the best one that we find with miscarriage and early pregnancy loss is the Pink Elephant Support Network. The other two, SANS and Red Nose, have joined forces, and I talked to them about that one in particular because they've got a number that they can call 24/7 for bereavement support. The woman, the partner, family members, anyone can access that number. And then Hope Bereavement is just our local like counselling service for grief and loss, and we can do referrals to that clinic for the woman, or they can self-refer. The other thing, sorry, I should mention, which is at the top, is that we now have a Bowen Health maternity microsite. On our Bowen Health maternity microsite, there's now a pregnancy loss section, which went live in, I think it was April last year. Right, next slide. So this is what our pregnancy loss section on our microsite look like. You can go through, like if you just put Bowen Health maternity in Google, if you click on that, you'll go to maternity's front page, and if you scroll down, there's a tile that says pregnancy loss. So that's another way you can get there. When we see the women in our clinic, we actually give them a business card that has a QR code that takes them directly to here. So then they don't have to go through all the happy baby stuff to get to this information. So it's broken up into miscarriage, stillbirth and neonatal death and support services. And if we flick to the next slide, this is in the miscarriage section, and we've broken it up to, you know, up to 14 weeks and then for where does it say, 15 to 20 weeks. And in there's patient information sheets that the woman and the partner can access. And when we see them in the clinic, we can go through this with them. Next slide. The other thing is, back on that slide, there's a there's a link to, it says miscarriage. When you click on that, it goes to the Safer Care, sorry, Alex, the Safer Care Victoria's website that has the miscarriage patient information sheet. And there's lots of good information on that with what's miscarriage, the 3 options that Alex has spoken about, as well as there's information about the red flags, so heavy bleeding, all of those things that Alex mentioned before. So it's actually good to, you know, if you can give that to them in your clinic, it's actually quite helpful because then they're a bit prepared before they come to their appointment with us. Saying that, we do actually send them the link to this when we make that first phone call, if they're happy for us to, just again so they can have a bit of a read and a bit of a heads up before they see us. And rather than them just Googling random stuff, this is a really good place to send them. And the other one I thought I'd mention is, it's not on our website, but it might be helpful in the clinic on bleeding and early pregnancy. And again, lots of good information. Right, next slide. The other thing I want to mention is that we have a really strong relationship with the Geelong Cemeteries Trust, and in October last year they opened up their pregnancy and infant loss memorial garden out at their cemetery off Surf Coast Highway. And so what's amazing about this is that all pregnancy tissue at Barwon Health, after a D&C, or if the parents decide they don't want to have the baby or the ashes when the baby's under 20 weeks, it gets cremated by the Geelong Cemeteries Trust, and it's in a very respectful way, and it's actually scattered around this garden. The other thing is this is free, the parents don't have to pay for it, and if the parents want to acknowledge their pregnancy, they can choose to have a leaf engraved and placed on the tree. There's no time limit. It might be 10 years' time that they decide, actually, I want to do this, then they can contact Geelong Cemeteries Trust and organise that for them. Next slide. So just a little bit at the end, just about self-care and looking after ourselves, because dealing with women during this, you know, miscarriages and the grief, it's important that we need to take care of ourselves. I've just popped a few things. I'm not sure, sorry, if there's anything specific to GPs. So I have added the RANZCOG member support and wellbeing website, and then also just basic stuff like informal debrief with your colleagues, a formal debrief if you need to, speaking to a trusted colleague, seeing your own GP, or seeing a counsellor or a psychologist, just to sometimes offload some of this stuff that we're carrying. And also it's important that, you know, go do something that you enjoy to fill your cup, like sitting on the beach, you know, painting, drawing, whatever. And I think that's it. Oh, and I've just put some Australian education resources and websites, just in case if there's anything you want to look at a little bit further. That's everything.
Thank you. Excellent. Well, Kate is a wealth of information and she's really experienced in this area. So I think if you had a particular patient that you were really concerned about and you weren't sure where to go, you could also contact Kate or Edwina through the Epas email or the mobile phone, and I'm sure they'd be happy to talk it through with you and work out the best plan for your patient.
Yeah, and we've definitely, I've had GPs, I think I've had maybe 2 GPs that in the past have called me and just wanted to know if there was anything else that they could offer the women that they're seeing in regards to bereavement support. And I thought that was really good. And also I'm actually starting to see more women, when we do make that initial call, when I talk to them about the support services like Pink Elephants and Red Nose, that the GP has already gone through that with them. And I just think that's so amazing that the word's getting out on those bereavement support services.
And acknowledging that what people are going through.
Exactly, yeah.
Absolutely. So Helene, should we open it up for any questions, if there's any burning questions at the end of our segment?
So there is just a couple of comments on the Epas manual, which I'll leave just for now. But there is a 2 questions. Hi, Alex. 2 separate questions. What is the significance? What is the significance of embryonic bradycardia on an early ultrasound, for example, 6 weeks? And how would you counsel the women the significance of that while awaiting the recent scan?
Yes,
the recent scan in 2 weeks.
To repeat the scan in 2 weeks. Is that the second part of the question?
Yeah.
Yeah. Look, so interestingly, like I agree, I used to be concerned about that when you saw a low heart rate initially. But then looking at this table here, which I actually skipped, so thank you for that question because I've been able to go back to the table I skipped over. But here at 6 weeks, so when the gestational sac is just around 10 millimetres, and you've got a fetal pole there, but the fetal pole is still going to be small, like just a couple of millimetres. It's not uncommon to see a low heart rate, and I thought that was new information to me. That 6 week mark, that can be a common finding. Look, I think in that situation, I would just be transparent with the woman and just say it's really early days. The pregnancy is a couple of millimetres in size. We can see a fetal heartbeat there, which is reassuring. We hope that the heart rate increases as the pregnancy grows, and then do a repeat scan in 7 to 10 days.
Thank you.
Does that answer that question?
I'll get back to you on that one. But the second question from this person is, for women who do have private health and plan to go with private obstetrics care, who present with early pregnancy bleeding, would you suggest EPAS or to go via the private route and calling private gynae/obs directly? In brackets, I understand different providers may have different preferences, read this, but do you have a general guidance in the Geelong region?
Yeah, it's tricky to say. So I work privately with OGB Surf Coast, and I certainly would be very happy to see women very early. So usually when they've confirmed their pregnancy, they'll get a dating scan organised by their GP, but sometimes not, and we will do that initial dating scan in our rooms. Most gynaecologists now have an ultrasound in their private rooms and can provide that ultrasound on site. So certainly I would see women early with pain and bleeding and do that process myself. If they occasionally I'll see women who are uninsured, and then I will refer them back into the Epas clinic. Like, for example, if they needed a suction curette, then organise that in the public hospital. And then sometimes, I think a couple of times I've asked Kate to do some follow-up there as well with myself, just so that the addition of what Kate can provide, Kate and Edwina. But yeah, I think the simple answer is I reckon the first port of call should be their obstetrician gynaecologist. Because women have private health insurance, they're paying for that, they should be able to use it, and we can provide in private usually a pretty, I guess, comprehensive service with ultrasound and then a management plan.
Okay, one more question before we go on to the next speaker, and then at the end I'll come back to you about the EPAS comments and stuff that they'd like addressed. I have a question regarding uptake/referrals for extended carrier screening rather than just the SMA/Fragile X CF screening. Is this something that OBS are doing more of, or mainly just pre-repair?
Yeah. So the pre-pregnancy genetic carrier screening. Look, to be honest, I think still just doing the limited screen. I think reserving the extended panel for couples that are at particularly high risk, depending on their demographic and their family history of genetic conditions. It is definitely a more expensive test. I don't know off the top of my head, I think it's like $800 to $900, whereas the limited panel is more like $380, I believe. So at this stage, I send women the link for the testing, which does talk about the limited panel and the extended panel, but I don't think I've had any patients do the extended panel. Okay. Because I think it's also important to talk to them about what are we going to do with that result. If the woman is a carrier, then their partner will be tested to determine whether they are a carrier, and then they'll have genetic counselling. But if they're both a carrier and they have a 1 in 4 chance of having an affected child, then they need to understand what the implications of that particular condition are. And if they wanted to avoid that condition, then really their only option at that point is IVF with pre-implantation genetic diagnosis, which the cost of IVF is coming down, but that's still a pretty expensive undertaking and isn't yet subsidised. So I think it's also important to talk about what will we do with this information.
Okay, thank you very much, Alex. That was fantastic. I will now hand straight over to Dr. Deb Karmakar, who will commence his presentation. Thanks, Deb.
Thank you. Just checking, is technology working okay at your end? Helene?
Yes, it is. Yes.
Okay. Good evening, everyone. And I resonate with Alex. It's a little bit strange talking to the slides without any feedback, but thank you for the opportunity. So I'm an obstetrician and gynecologist based in Bowen Health and Western Health, and this is in the context of the Perineal Clinic we've set up here recently. My partner in crime is Kate Cohen, our nurse and midwife, so you'll hear from her again. So I've got a true story, and we'll call this exemplar patient Mrs. X for now. Gravida 2 para 1 with previous 1 vaginal birth, delivered last year at 41 weeks and 2 days, came in spontaneous labor, really fast labor. First stage was 2 hours, second stage was 11 minutes, 3.9 kilos baby, had a vaginal birth, so precipitate labor. Experienced a second, what was documented as a 2nd-degree tear with a liter of postpartum hemorrhage controlled with uterotonics. And a rectal examination was appropriately done before and after repair. There was a little bit of delay as the registrar was inundated with other emergencies. The patient went on to have some ongoing fecal incontinence, saw a physio via proactive care plan organization by the GP. And then when the physio was not able to really help with the fecal incontinence, the GP very kindly and very proactively also referred on to the Perineal Clinic. There was some improvement with the fecal urgency with physiotherapy, which is quite typical with these women, but there was still daily passive fecal incontinence going on, which means incontinence without an overriding urge to defecate. So every time the patient would look at the underwear, there was some staining of fecal matter. So we did, at that time when the patient came in, we had a 2-dimensional endoanal probe. So it's very obvious. So I don't know if you can see my arrow. What we can see, so this black line is the internal sphincter. It's more or less intact. And this one between, say, 9 o'clock and 12 o'clock position, in the gray hazy area, there is a big shadowing. So that's the external sphincter completely missing in that sort of sector. So with the internal sphincter intact and the external sphincter full thickness defect, it's a 3B tear, which was at the time of birth missed and labeled as a 2nd-degree tear, which happens. There is a lot of evidence that in about 10 to 20% of women, even with a routine rectal exam, sometimes tears will be missed just because the tissue is quite friable, edematous, and things like that. So on the day, we also did some anorectal manometry. So just to explain, the endoanal ultrasound looks at the bowel sphincter anatomy, and the anorectal manometry looks at the bowel sphincter and the bowel mucosa function. So we did anorectal manometry on the day, and it was obvious that there was some ongoing rectal sensitivity. So the pressures were a little bit lower than what we would expect. This is the normal sphincter anatomy from another pregnant patient on the day. You can very clearly see that the outer gray area of the external sphincter is completely intact compared to this massive shadowing in the top left quadrant on the exemplar patient's imaging. So the patient was kind of leaning towards having more children. So we had a detailed discussion. So usually in these consultations, and Kate will speak to these a little bit more, we usually have Kate present, which is a massive help because she's often part of journey of such women in the birthing room, sees them in the postnatal visits. So it's very good to have that midwifery sort of perspective in the room. So we, three of us, the patient, myself and Kate, we had a discussion, and the patient made a decision of just waiting and watching because the urgency was improved with the physio input, and do some pelvic floor exercises. The implications for the future are that at some stage she will need an external anal sphincter repair. So most gynecologists would be of the point of view that the next pregnancy, the patient should ideally have a Caesar, because there is already a weakness in the sphincter and scar tissue. You don't want the patient to have a second tear in a new area of the sphincter. You know there is one defect in that quadrant. You don't want a new tear and make it a more complex repair. And then once they have completed childbearing, to organize a secondary repair of the chronic third-degree tear. Some people would say, well, there is already an existing third-degree tear. They can probably have a normal birth, unlikely or low risk of having a repeat third-degree tear overall. And then, we can do a delayed repair. So the jury is out on that, but most gynecologists, I think, would agree to have the next baby with a Caesar and then plan a delayed sphincter repair when the patient is more symptomatic or really wants a repair. So I think that case truly reflects what's going on in the community to the women we're catering in Barwon Health. I think we are noticing that the GPs are yourself, you are very proactive in dealing with postnatal complaints, and we are increasingly seeing a lot of women. So that's why we thought that this is a good forum to sensitize the audience with what this clinic really means, why is it needed, what are the services we are providing, and what's our vision for the future. So moving away from our exemplar patient to sort of pan out a bit and taking a more helicopter view, looking at the Australian context, there is a lot of work being done in this sphere. So birth-related severe perineal trauma, which means a third or a fourth degree tear, it affects up to 5% of Australian women overall. Having said that, there could be almost 12 times variation. So in some places, you might be seeing 15 to 20% third and fourth degree tear rates, and in some places you might just only see 1%. So 3 to 5% is the ballpark nationwide average. The federal government recognizes this as a priority area, and the distress associated with this, which all of you would have seen in your practice, is that there is a lot of perineal pain. 1 out of 5 women with a third or fourth degree tear have ongoing fecal and flatus incontinence, painful sexual intercourse, reduced quality of life, very closely linked into body image issues and depression. So it's really quite a morbid condition. The sad part is that most of these women are actually otherwise fit and well. So it's really this birth-related trauma which adds to their comorbidity. Additionally, if the diagnosis or the workup is not accurate, only 30% of such women in the community will go on to seek specialist care, because there's a bit of shame and guilt attached around it. So the uptake, unless it's sort of suggested to them that, look, there is help available, there is a specialized clinic available, there is a specialized service available, a lot of women will walk away from addressing this, and when they get older, the symptoms will become worse, because to some extent, initially the puborectalis muscle, which is part of the pelvic floor, will be able to provide some support to the bowel continence mechanism, but as they get older, we know the pelvic floor becomes weaker, so the symptoms do tend to become worse. So to this effect, the Australian Safety Commission has produced a beautiful document. It's got really common sense advice and evidence, which we have known for many years, but it's kind of in the form of a consolidated document. So how to avoid tears in the first instance, and then how to diagnose and how to repair. There is some information useful from a general practitioner aspect, which I will speak to in due course. So I think that's a good document for members of the audience to have a look at. So to now zoom into a more Victorian context, at present there's really only 5 specialized perineal clinics. So the Mercy Hospital for Women, where I had the experience of running one such clinic, we were able to see 4 women per month. The Royal Women's Hospital has got a similar clinic. I think they're able to see slightly more number of women. Monash Medical Center typically would be able to see 4 women a month. John Kerner Hospital, I'm also attached to this service. They're only able to see about 4 women a month as well. So University Hospital Geelong is the first regional service of its kind, which is providing specialized anorectal studies. And we are currently catering up to 12 patients a month. So reasonably proud. So we've made a very quiet, under the radar kind of start. So now I think we want to talk more about it as we feel ready to be able to advertise the service a little bit more. Specifically, narrowing it down to Geelong, there has been a bit of an issue with perineal trauma, and that is why we thought that it would be good to bring this up. So in my talk today, I won't be talking too much about diagnosis and management of perineal tear. Rather, I would be talking about what to expect in the community in your practice and how to link into specialized service. And while the women are waiting to be linked into us, what you can do in the interim to sort of provide some ongoing high quality care. So if you look at the WHA bundle, which is there in the Safety Commission document, that was a project that was that Barwon Health was part of till 2020. Then the pandemic came, and one of the lead midwives was very proactive and did an excellent work in absolutely decimating the perineal trauma rates. Unfortunately moved on. There was a problem with organizing educational sessions. Face-to-face education had to be stopped. We could not do our regular prompt sessions. So we saw a massive upsurge of perineal trauma cases. So if I'm sorry, I can't see my slide numbers. I think these are the slides, Kate, you are speaking to, aren't you?
No, this one's yours, Deb.
Okay.
We're on slide 14.
Okay, thanks.
Yeah,
if you can
okay.
chime in when it's your slide, that'll be great because I can't see my slide number.
Yeah, that's fine.
Okay, so every year we get the hospital acquired complications report, and very distressingly, we were an outlier amongst the public hospitals really across the country in terms of our perineal trauma rate. The projected statistics shows that 1 in almost 6 women were at a risk of a 3rd or a 4th degree tear. So it immediately rang alarm bells, and this report came to us in June. So that was just before I started. And so specifically, my appointment to the hospital was with the purpose of starting this perineal trauma clinic, because by doing that and making it multidisciplinary, by involving midwives, we thought it would be an opportunity to bring in more awareness and education. So while we are treating the perineal trauma postnatally, there is a lot of evidence from other centers that there is always a feedback loop which goes back to the birth practitioners, and you are able to reduce birth trauma from there on. Also, knowing that we've had a very high incidence of perineal trauma, this service became an absolute necessity. So in the past, most women with a 3rd or a 4th degree tear would get some information at birth on the ward, have a physio referral, which they would access either through Barwon Health, which was extremely hard during the pandemic. So they would get a telehealth in about 10-12 weeks with a physiotherapist, or see a physiotherapist in the community through a care plan. And then they would come to a general gynae clinic, where typically the most junior doctor on the day would be given these patients to see. And the problem was often they did not have the experience to deal with these problems. And also what happened was there were a lot of women who, apart from anorectal dysfunction, with the amount of tissue damage and suturing needed, also had a lot of scarring issues with introital anatomy distortion. So they were really not equipped to handle all of that. So the hour of the need was to set up this specialized clinic. So with that brief in hand, what we did was we set up this clinic. So we started seeing our first lot of women from August. So the reason I'm showing these slides is just to highlight for those of you who have an interest in women's health and shared care providing. This document, which I've referenced to earlier, has got some really good tips you can advise your clients as to, for example, doing perineal massage from 34 weeks, starting some pelvic floor exercises from 34 weeks, and that sort of stuff. So some advice which as a GP with women's health interest you can provide to your women. And also this is also a good document for you and the midwives and for obstetricians to sensitize to the women what interventions we can do during labor. For example, hot water compresses, controlled delivery of the head, selective episiotomy, just basic stuff to mitigate or lower the risk of perineal tear. So specifically, we know the risk of perineal tear is 3rd or 4th degree perineal tear is higher when it's a primigravida woman. Certain ethnicities, for example, South Asian, Asian, and some birth-related factors, for example, malposition, occiput posterior, occiput transverse, and instrumental birth, specifically forceps, sequential use of instruments, and also uncontrolled delivery of the head or compound presentation. So this guide is a good reminder. So if you're doing shared care, sharing this document with the women, giving them a simple explanation is often a good tool for them to be ready to deal with this kind of a situation. So coming to the context of this clinic, we thought that we'd run this clinic in 4 phases. So the first phase was August and September. So we started siphoning patients who would typically come to a general gynae clinic, would see the most junior HMO. We started siphoning these women into a specialized perineal clinic. So at this time, we only had the option of a 2D translabial ultrasound, which the evidence suggests is still an excellent tool. Its accuracy is about 90%. And some people, for example, Professor Peter Dietz in New South Wales, he could argue that for endoanal ultrasound, for anal sphincter complex ultrasound, this is actually a reasonably reliable tool. The problem is at the end of the day, with a 90% accuracy, you're still looking at it as a screening test. It's not a diagnostic test. So we had this vision and mission of bringing gold standard diagnostics for the clinic. So we kick-started the second stage of the clinic, where we have now got a 4D endoanal probe. And I wish I was able to bring photos. So if you look at it, it's beautiful demonstration of the sphincter anatomy. Really, if you have the expertise, if you can't make a mistake with diagnosis, and the accuracy of that is almost 98%. So we were quite happy, but not complacent, that we've been able to achieve gold standard in terms of anatomical diagnosis of anorectal dysfunction. We still don't have access to anorectal manometry. So while I did show you anorectal manometry from Mrs. X, that machine was given to us on a trial basis. The good news is we are very likely to be able to get anorectal manometry from July, and that is the gold standard in anorectal function. So scanning is for anatomy and anorectal manometry is for function. So we are hoping to have that in stage 3, and stage 4 is really where we at the moment, it's multidisciplinary in the sense we've got a midwife and a doctor, and we've got very good physio, Naomi Nolder, who's able to provide us advice, but she's off-site. We've got 2 very friendly colorectal surgeons. So Pia Bernardi is one of them. We can always get advice from them, get women to see them off-site on a different day. But really the goal is from next year on, have everything under one umbrella and make it comparable to the best perineal clinics in other countries. So we are very grateful to the Barwon Health Foundation, who were supportive of our stage 2 and helped us buy the 4D endoanal probe. And they are potentially also, we are hoping that with their active input and assistance, we will be able to obtain some funding for the anorectal manometry, which will mark stage 3 of our clinic. In terms of financial context, currently MBS clinics, I don't know if you are aware, MBS clinics have been put on hold. You can't actually set up a new MBS clinic in a public hospital because nationalized model is coming. It's a bit of a holding pattern. The thought process is that the final decision would be made after the elections, federal elections. So if it were to be an MBS build model, in 6 to 9 months, the equipment is cost neutral, because each procedure, if they have a consult, an anorectal manometry, an endoanal ultrasound, the MBS billings themselves could add up to $1,100, $1,200. So in 6 to 9 months, the cost of all this equipment would be covered, and whatever extra is accrued from there on could be used towards other women's services. For example, if we continue to accrue MBS billing through our perineal clinic, 1% of that goes to the special purpose fund, and then we can help the early pregnancy clinic. So not so relevant from a GP perspective, but kind of gives us all an idea that running one clinic efficiently also helps another clinic in terms of a hospital model. There is also some concern that the private health insurance is declining by the year because of the premiums going up. So currently in most of the LGAs in Geelong and around, women in the reproductive age group, the private health insurance coverage is around 55%, which in the federal sense is considered low coverage. So there is a big need for the community to have a publicly funded specialized clinic of this type. Kate, who is instrumental to this clinic, she's going to speak to some of the slides and give her perspective of the clinic.
Are you happy to flick the slides for me, Deb?
Yeah, happy.
Yeah, thank you. So I wear a few different hats, obviously in maternity services, and Perineal Clinic is another area that I work in with Deb, which I came on board, I think it was again in October last year. And it's been such an amazing clinic for women in our region. So this slide just goes through some of our statistics since September. So we've seen roughly 86 women. 72 of those were postnatal women after a 3rd or 4th degree tear, and then 14 women have been antenates, which has been really good that we're able to see antenates in this clinic to be able to give them just some good feedback on how well their 3rd or 4th degree tear is healed, and also prepare them for their birth with their second or with their subsequent pregnancy, and give them the information so that they can make an informed decision whether or not if they would prefer to have cesarean, or if their perineal tears healed really well, that they can go confidently into labour knowing that everything has been checked prior to going into labour.
Kate, I'll just jump in for a quick minute.
Sure.
So without inundating the audience with too much didactic information, for us in this clinic, Kate and I, we have made it a point, we don't make recommendations for women. We give them information, and we give them all possible support and resources, and they make an informed decision. And often we tell them to go home, assimilate the information, have a think about it, and then come back to their obstetrician. So in terms of what is considered safe, if someone's had a previous 3rd or 4th degree tear and they're pregnant now and they have any form of bowel dysfunction, so especially incontinence, or fecal or flatal incontinence, and to some extent if they have fecal urgency, most people would say they're safer having a Caesar, because they're at extremely high risk of worsening of bowel dysfunction. In some select women with no incontinence but only urgency, if I have seen on endoanal ultrasound a good sphincter complex, the anorectal manometry is not that bad, I have told the patients that, look, I think if you're kind of, in the in-between group, if you're really keen, you can try. So that providing the information and statistic is really important. So this becomes very important when they are asymptomatic. So they are asymptomatic, you do the scan, but what you can see is the practitioner in the last birth thought it's a 3A tear, so only less than 50% of sphincter tone. But on the scan, you see that it's a full thickness defect, so it's really a 3C. So then we again don't tell the patient what mode of birth they should have. We say that, look, it's actually a bit worse than what the obstetrician last time thought. It's a 3C tear. You've got a very high risk of ongoing and second tearing, more fecal incontinence. Have a think about it. Maybe you might want to consider Caesar. And sometimes we can see that it's a repair and there is just a lot of scar tissue and just holding on by a thread. We'll tell them that, look, and we also look at the ultrasound scans of their babies. You've got a relatively large baby, you've got gestational diabetes, it's just holding on the sphincter. It might tear quite badly this time. So again, they take home all that information and then they make an informed choice. Kate, all yours, sorry.
That's okay. Next slide. So just some details about the Perineal Clinic. So the role of our specialised clinic is to diagnose the condition or to confirm the diagnosis already made by the GP or referring specialist, and to then formulate a treatment plan. So this may include getting the physios involved, diagnostic testing, conservative management, or potentially surgical interventions. It also includes a plan for any ongoing GP input and guidance of obstetric management. The other thing is we are getting referrals from other healthcare services such as Ballarat and I think that's the main one we've received. Oh, and Werribee so far to our clinic. Yeah, to our clinic.
A fair few from Werribee Mercy, yeah.
Yeah, which is great because then we're being able to see these women, give them the information that they need, and then they can go away and make an informed decision. And also just having their perineum assessed and giving them that peace of mind. Next slide.
It's on.
Thanks. Oh, sorry. So the patient journey at Barwon Perineal Clinic. So we see women who have had third and fourth degree tears and acute healing issues, roughly between 6 weeks to 6 months, saying that we generally see our postnatal women around the 8-week mark, just purely because by then they've at least had a physio appointment before they come and see us, which I think makes quite a difference if they've seen the physio and had their input prior to seeing us. Any anal vaginal healing, perineal healing issues greater than 6 months postpartum, specialised assessment of anal incontinence, which can be multidisciplinary, a range of management options from conservative management to surgery, anal sphincter ultrasound, physiotherapy input, and colorectal liaising. Just to come up with, it's good to have all these allied health services involved in our clinic, because then we can refer women on to, say, colorectal for their input if they need further management. Thanks, Deb. So the way our clinic runs is that we run it fortnightly, so every second Thursday morning. We have 6 appointment slots. Generally, the first 3 are for our antenatal women, which the appointments are longer. They go for roughly 45 minutes, so then there's time for them to have their ultrasound and to go through those results. And then we have 3 postnatal slots to see women. So again, there's a bit of movement with those appointments, but we can generally see 6 women every clinic. And so with these clinics, so we see the women with third and fourth degree tears, like I said, between the 6 weeks to 6 months post-delivery, any acute healing issues, and then any bowel incontinence control issues after childbirth. Our clinical exclusions are for postnatal checks or debriefs. Ideally, this needs to be done separately and prior to our clinic. And if that's the case, usually when I receive the referral and see that they need a debrief, we organise that first, and then we organise an appointment with our clinic afterwards. And also with all our perineal clinic appointments, I contact the women to schedule their appointment date and time, but I also talk to them about what to expect from the clinic, because if you just turn up on the day without realising that you would need a vaginal examination or a rectal examination, I think that wouldn't be ideal. So that's why we always give them a phone call prior to their appointment, just to give them a heads up to know what to expect. We also postpartum, so who've had first or second degree tears, we don't see those women, and patients may not be seen in this clinic if they've delivered more than 6 months ago, but we base that on depending on what their symptoms or what their situation is.
If you do refer someone, we will see them, but they'll probably be slotted into my gynecology clinic,
Yeah.
because we have the setup, but they'll not be seen in the perineal clinic, and the wait is typically a little bit longer.
Did you want to talk about this one, Deb, or do you want me to?
No, you can carry on. Yeah.
Yeah.
That's...
So this is the referral to be accepted, referring GPs, medical specialists, which I think is it on the Health E-net? So, I'm not sure if it's on there yet.
Yeah. So at present, if you want to refer, and those of you who are already referring, just do the usual referral you are doing to other gynecology clinic, but just mark for attention of the perineal clinic. Yep. And ideally, if you can provide some of this information, that would be amazing. There is an electronic and a specific form that's been created. It's been ratified by Bowen Health, but it's just waiting some feedback from, I think, the consumer groups and stakeholders, including GPs. So we don't have that final form ready yet. So you can just continue to refer on the usual form.
Yeah. And it's really helpful if the woman has birthed at another healthcare service, if you're able to attach to the referral their birthing clinical summary from that time, as well as if you could get the post-op note, or from their 3rd or 4th degree repair, and attach that and send that to us as well, which makes a big difference. The other thing is, if you're referring antenatal women, if you could do that as soon as you can, that would be ideal, because it gives us a bit more time to be able to slot them into their appointments, because we generally see antenates around the 30 to 34 week mark. So it's helpful if we get the referrals sooner rather than later, so then we've got time to plan and slot them in to be seen. And then maybe the next slide. At the moment, we're in the process of getting, like Deb said, some patient information sheets as well as questionnaires that's going through the consumer group just before we can give that to women. So it might be that we give the questionnaire to women just before their appointment, or we may even send it out to them 2 weeks prior to their appointment, just to get an idea of what their symptoms are. The specialised consulting and assessment, pro forma, validated, ratified, patient info. Yeah, sorry, so I don't know what that part is.
That's fine. All of these questionnaires are validated, used in other clinics, and they have been ratified by Bowen Health, but just waiting consumer stakeholders' input. In your rooms, if you wanted to do one simple questionnaire to look at bowel dysfunction, you can do the St. Mark's questionnaire. If you, I might be able to email to the nodal person, maybe to Helene, and she can disseminate. The St. Mark's questionnaire would take your patients 20 seconds to fill out, and you would know instantly how bad their bowel dysfunction is. So I'd highly encourage, if you have the time, to sort of ask that question around the St. Mark's distress score, and also just the basic simple Bristol stool type. Most women in Victoria are quite well versed with the Bristol stool type. It gives us some idea. So for example, if you've got a woman who's recovering well but got some fecal urgency, and you ask them their Bristol stool type and they're saying it's a 7, so we know that it's a very runny stool. So if they bulked up the stool with Metamucil, then probably the urgency will be a bit better. So that sort of stuff is quite useful at the community level. I think we will talk more about the management specifics if we do a future update in due course, which we will. The idea of this session is purely to just providing a sensitizing stimulus. So obviously the GP form is not final. So any feedback, if it's jumping into your minds now, we'd be very happy to hear from you. And also very happy to take any questions and comments. Just a big note of thanks for ongoing support and partnership. I've worked in a few different hospitals in Victoria and overseas, including in the UK. I think the GP circle in this side of town, I find it very patient-centric, and most patients are very attached to their GP, which is always a good sign. In some other demographic locations in Australia, I've noticed that they can be a bit detached from the community. sort of GP care. So just very grateful to all the support you're providing them. Very happy to hear from you. Like the early pregnancy assessment clinic, the number is the same because the midwife is the same, which is Kate Cohen. So if you've got any questions about Perineal Clinic, you can give Kate a ring. We've also got a specialized email address, which we will send out to Helene to disseminate within your group. And looking forward to hearing some questions and thoughts from you.
Sorry, I just wanted to add if you need to contact me, just do it via the email address, just because the phone that we use for Epas, we also use for fetal medicine unit. So ideally we want to keep that separate to Perineal Clinic, but I'm more than happy for you to send an email and then I can contact you directly.
Very rightly said, Kate. Thank you. And apologies for jumping the gun there.
That's okay.
Hi Deb, it's Jade here from the PHN. How are you going?
Good, thanks.
Did you mention you were after questions now?
Yeah.
Yeah, no worries.
Absolutely.
Helene must be having some audio issues, so she's not jumping in. Let me just check what we've got here. Is there any public pelvic floor physio associated with this model, or they mainly outsource to private pelvic floor physios?
We've got a very experienced physio. There's actually a few, but the one who's got a special interest in pelvic floor is Naomi Nolda. She's a big advocate for these issues in the public setup. The only issue is with the backlog with COVID, where they were not able to do face-to-face appointments at all. She's quite inundated with work, so she will accept all referrals, but the patients might be waiting a while. But if they eventually do get to see her, they get amazing service. Usually the more sooner accessible option is to get a care plan with some rebate and see a physio in the community, and Geelong's quite a few who are really good. The ones which we have been repeatedly getting excellent sort of information, good patient experience, and just from the communication we receive our inner strength. So what I've started doing is I've started giving patients, so they would come with an assessment from an inner strength physio. I would see them and I would say add some additional feedback, so it becomes a bit of an indirect dialogue, and it's been really good. So yeah, we've got there's a few. So one good resource is to go on to the International Urogynecological Association website, and the physios, there is a search box and they can search for physios by using postcode. So that's one option. And I believe the Continence Foundation Association also has got a search function where private physios could be looked up.
No worries, thank you very much. Someone else has mentioned, excuse my ignorance, but I didn't know that there was a lot of public outpatient gynae accessibility in Geelong, example colonoscopy only HCC holders. Is there a general gynae clinic form and inclusion criteria for this?
Absolutely. Traditionally, the Geelong gynecology model was that patient, so it was like really like an MBS funded clinic. So patients would be seen by clinicians in their private rooms, and those who were not able to afford private health cover for operating would be sent to Bowen Health for a pre-admission quick check and to be operated on a public list. So because of the so for two reasons. One, there is an overriding federal government move to move away from MBS model, because I think the federal model perceives it as a bit of double dipping by public hospital. So they're trying to set up more and more non-MBS, which are called public gynae clinics. So about a couple of years back, this was started. So really, for any gynecological condition, women can be referred to Barwon Health. as a public patient, and now the model is that even if patients have been seen in private rooms and they can't afford surgery and have to come for operating in the public unit, they will have to be seen by the public surgeon beforehand so that they have continuity of care. So there is both a public model and a continuity of care model. And the other thing married into this was, the only exception being, for example, for colposcopy, because of some constraints around how the department is generating funds for the hospital. Yes, for colposcopy, it is only for concession holders, and I believe for DVA card holders, which is there is some talk that that's going to change. So the unit is looking for some innovative models to try and circumvent that by getting additional funding. If it's obvious gynae cancer, I think GPs should consider maybe referring directly to either Royal Women or Sunshine Hospital, just because it will save some time. Having said that, if an urgent referral is made with suspected cancer, if it's seen by a general gynecologist, we've got a very good direct communication with Royal Women's Hospital, and they've been fantastic as being our oncology referral hospital. So usually it's not a problem if some cancer gynae patients come to see a general gynecologist here.
Great, thanks for that, Deb.
On that note, we are now also providing dedicated pelvic floor services. So I'm kind of leading that because I've got an interest in that area. So I've done 2 fellowships, one from the UK and one in Australia in pelvic floor dysfunction. So feel free to refer them to my public clinic. We are also setting up a public urodynamics clinic. So for women with bladder incontinence who need specialized testing, we should be able to provide them publicly funded urodynamics testing for accurate diagnosis of the type of bladder incontinence.
Great. Another question. Regarding the Perineal Clinic, do you accept referrals for patients that have been diagnosed with grade 1 or 2 tears, but their symptoms greater than what you would usually see with these injuries?
Absolutely. So once the documents and the criteria and the referral form is finalized, we will be sharing it with you. And I think I'll try to pull up that slide. And we did mention that if you think that the symptoms are more severe than what the grading was, please do refer them to us, because as I mentioned, in about 10% of women, even with a diligent examination at the time of birth, a 3rd or a 4th degree tear might be missed. So then in that case, we will do an examination, a vaginal and a rectal examination, and then supplement that with an endo-anal 4D ultrasound to look at the sphincter anatomy and an anorectal manometry to look at sphincter function. So we might find that the anatomy is normal, but the manometry is very abnormal. So it's then a neurological issue. So there is probably some nerve damage. And in that case, we can initiate them on neuromodulators like imipremine. So imipremine, the antidepressant in low dose, works as a great bowel neuromodulator. So we then would recommend to you that these patients will keep coming back to you for repeats of imipremine. So yes, so the short answer is if you find such patients, absolutely do send them to us.
Fantastic. Thank you, Deb, and thank you, Alex and Kate, for your amazing presentations tonight. We don't have any further questions. So is there anything else any presenters would like to add to wrap up?
No, I think Helene had mentioned that she maybe had some like Epas Clinic, like logistical questions that she was going to hold.
Go back up to the top.
If you can't access them, that's fine.
Helene, are you there?
No worries. Jade, I'm happy if people want to, you can give my email address out if people want to email me directly or email Kate or Edwina on the Epas email. We can hopefully clarify any.
And same, I'll send you, you've got my email already. So either my Gmail or my Barwon Health email, happy to take questions on any stuff related to pelvic floor or perineum from there on.
No worries. All right. Thank you, everyone. And thank you to our attendees. And have a great evening.
Thanks, Jade.
Thanks a lot.
Bye all.